January 11th, Tuesday, and we have in Ledge Council, we're going to do a drive-through or a fly-over on a bill that's in Human Services right now that crosses sort of our interests, H13. And what we're looking at is draft 3.1, which can be found on Human Services Committee website. And you can go ahead.
Great. Good morning, Jen Carby from the Office of Legislative Counsel. We are looking at the proposed, and I have not gone through it with their committee, it's been posted over the weekend, I believe, the Human Services Committee's draft amendment to H13, which is an act relating to Medicaid payment rates for home and community-based service providers and designated and specialized service agencies. They are proposing a strike all. There's some highlighting in here. It's to show them, like I will do for you, and I come in with bills changes from the previous draft 2.1. So everything is not necessarily just what's changed from the bill as introduced. The idea behind this bill is really to create a process for identifying what rates would be appropriate for providers of home and community-based services and in the Medicaid program, and to try to have that information provided to the General Assembly so you can make decisions when appropriating. That's kind of what this does. So it starts out in section 1 by amending some definitions in 33 VSA section 900, which is in the chapter on rate setting, mostly nursing home rate setting, but this is expanding that. And so this is adding a definition of home and community-based services. It started out a bit more narrowly focused on choices for care services, and then we had some similar provisions for the designated and specialized service agencies. This instead makes it a broader definition that incorporates both. So this would say that home and community-based services are the following services provided pursuant to Global Commitment to Health, our 1115 Medicaid demonstration, or a successor program. Long-term services and supports provided to older adults and adults with physical disabilities in a home or community setting other than a nursing home, including enhanced residential care services, home health and hospice services, adult day rehabilitation services, and assistive community care services, move brain injury below, and short and long-term services and supports provided to individuals with mental conditions, which is largely how it ends up in this committee as well, individuals with substance use disorders, individuals with developmental or intellectual disabilities, and individuals with a brain injury in a home or community setting for which the Medicaid rates are not otherwise established pursuant to statute or rule. We're capturing the universe of these home and community-based providers whose rates are not otherwise set in another way. Section 2 adds a new section to that chapter on rate setting, on payment rates for providers of home and community-based services. It directs the Secretary of Human Services to determine payment rates for providers of home and community-based services that are reasonable and adequate to achieve the required outcomes for the populations they serve. And when determining these payment rates, directs the Secretary to adjust the rate amounts to take into account factors that include, first, the reasonable cost of any governmental mandate that has been enacted, adopted, or imposed by any state or federal law. So Secretary is supposed to think about what it costs to implement a mandate that is not within the control of the service providers, and a cost adjustment factor to reflect changes in reasonable costs of goods to and services of providers of home and community-based services, including those attributed to inflation and labor market dynamics.
Yes, Leslie.
I'm not sure that this is something you know, but I'm just wondering about required outcomes. Like, where does that get determined? That's on line 11 on page.
I think for some, there are requirements in their contracting with the state to provide the services that dictate the quality of the outcomes.
So they go into the contract knowing the outcomes is what.
I believe so, but the agency would be better.
Okay, for sure.
Better,
I was just curious.
situated to answer. All right. And then, so that was shall consider. And then when determining reasonable and adequate rates of payment for these providers, the Secretary may consider geographic differences in wages, benefits, housing, and real estate costs in each region of the state. This has changed from a rules-based to just a methodology-based focus in the bill. Requires the secretary to establish a methodology for determining payment rates for these providers in accordance with this section. And some things that the methodology must do: it must provide a schedule for conducting studies of the Medicaid reimbursement rates paid to providers of home and community-based services. So rate studies, ongoing rate studies, including the rates adequacy and their underlying methodology that includes studying the rates paid to providers for each type of service at least once every 5 years. Set a predictable timeline for redetermination of base rates. Include a process for determining an annual inflationary rate adjustment, and, to the extent permitted by the Centers for Medicare and Medicaid Services, take into account the financial needs of providers that are paid on an enrollment basis and providers whose reimbursements may be negatively affected by client absences. And include a process by which a provider whose financial condition places it at imminent risk of closure may seek extraordinary financial relief from the agency, which is a process that exists currently for nursing homes, and use Vermont labor market rates and Vermont costs of operation. It requires the secretary to redetermine the payment rates for providers of home and community-based services in accordance with this section at least annually, and report those rates and the amounts necessary to fund them to various committees, including this committee, the Human Services Committee, the Appropriations Committee, and your Senate counterparts, annually as part of the agency's budget presentation. Section 3 is a provision of existing law on the rates of payment to designated and specialized service agencies that had very similar language to what we just looked at before, some more recent Human Services Committee amendments that stated that the Secretary of Human Services under current law shall have sole responsibility for establishing the rates that the different departments within the agency pay to the designated and specialized services agencies, DAs and SSAs. And then there's that language about reasonable and adequate to achieve the required outcomes for designated populations. And a lot of those same factors were in there. As I understand it, this provision was not implemented. There was some perhaps lack of consensus between the legislature and the executive branch about whether having sole responsibility is the same as having to actually do the establishing. So they took their, as I understand it, the agency viewed its sole responsibility for establishing these rates as discretionary and not mandatory. And so part of what this bill is doing is making it an active requirement for the secretary to do this determination. But we're just folding this existing section on the rates of payment to the DAs and SSAs into the home and community-based services in section 2. And so now, instead of repeating the same language twice, it would say Secretary of Human Services shall determine these payment rates for the DAs and SSAs in accordance with, go look at that section in section 2.
All right.
So the legislature still plays a role in what rates are paid, the DAs and the SSAs.
Right, so it's broadening that category of it's expanding your information, but still requiring it's still requiring the appropriations process to determine how much actually gets reported. But it's providing you with sort of up-to-date information on what it would cost to pay them at the rates that the secretary determines are appropriate, and then
So if I
decide whether to appropriate those for those appropriate amounts.
So if I understand, we had where Secretary of Human Services should do this and that they have the responsibility of doing it, but that was taken as discretionary. So now we're saying that AHS determines all these rates and they have to determine them in the exact same manner that was just up there for home and community-based. And take all those things.
Right, the DAs
into
and
it.
SSAs become
Okay.
part of this broader definition because they are community-based. So it folds the DAs and SSAs into this larger group whose rates will be studied and updated, at least informationally, on a regular basis. And then it will still be up to the legislature to appropriate the funds.
And they're to look at all those various criteria,
Right.
making sure that the rates are in line with, okay.
All right. Then we get to section 4 is an implementation update. And this would have on or before January 15th, 2026, the agency would report to this committee, Human Services Committee, and Senate Health and Welfare with an update on the agency's implementation of section 2, including the agency's proposed schedule for Medicaid rate studies and the methodology that the agency developed for determining payment rates for providers of home and community-based services. Instead of doing a specific rate study, becoming an ongoing rate study requirement. Oh, and I do need to change this. We have no rules. So the act would just take effect on passage, and I amended the title so that it is more broadly just home and community-based service providers, because we have included the DAs and SSAs in there. You have to update the effective date, so that's actually good to see. It would take effect on passage.
Brian?
I just wanted to ask a little more about this change. I'm just gonna tell you where I'm gonna find the line number. Page 3, line 3. So when you were speaking, you mentioned something about, I don't remember what you said exactly, so I'm not gonna try to repeat it, but it had something to do with like the interpretation of the executive branch of the legislative.
That was for Slater.
Okay, but it made me like, just the question I have is about this line though, which is,
Okay.
we are amending it. It says, the current statute says that that the secretary shall adopt rules that sets forth a methodology, but the law didn't say that they would then have to actually follow the methodology. Do you see what I'm saying? Like,
So this is what you're looking at that's crossed out there
Yeah.
is not, it was in the earlier version of the bill. Current law does not require, so current law on the DAs and SSAs does not require rulemaking.
okay. So essentially though, then what the Human Services Committee just decided to have it be cleaner and say, establish a methodology versus making rules to create a methodology.
There was testimony from the agency that they typically would not go through rulemaking to establish a methodology, that they do a number of set payment rates.
Okay,
Frequently, I mean, they have people whose purview that is, and they don't go through rulemaking, and it's a longer process, and they asked to take it out of rule.
because this is more consistent with current practice and it's more efficient.
That's my understanding.
Yeah, okay, yeah. I wanted to, when you mentioned the thing about the disagreement, I wanted to understand it more, but it wasn't about
Yeah,
this.
and I said that part only to explain why section 3 looks like this already is happening for the DAs and SSAs, and it's my understanding it is not happening. And at least anecdotally, I'd heard in the past that the agency had not have sole responsibility for establishing as a mandate to establish. Which I
Right,
think.
it's saying they have a responsibility to do it, but it doesn't say they have to do it.
It says they have sole responsibility for establishing. It does not say they must establish.
Exactly, yeah.
They are the only ones who have that responsibility.
So they could use the responsibility to not establish it. Yeah, exactly. Okay.
Which I think, you can make an argument for that. So this.
So we're making it clear, yeah.
I just want to, we're not doing anything in here that just isolates it to home and community-based services. They're going to, anything that the designated agencies do, any services, they will need to do this for those services as well, correct?
Well, we tried to describe the types of services that they provide, which is services provided to individuals with mental conditions, substance use disorders, and developmental or intellectual disabilities. So this was not individual setting based other than home and community. But it does not go into the type of provider themselves.
Right.
And so yes, it is limited to home and community-based services, but the definition of home and community-based services is broader than it is in the Choices for Care program.
I just, when I heard about this, I thought it was right after we had taken testimony on Success Payment 6 and school-based services. And we know that sometimes the reimbursements for school-based services are not quite where they need to be as well. And does this, I mean,
Well, it talks about short and long-term services and supports to provided to individuals with mental conditions. It's not adults only, it's not kids only. So I think arguably, but AHS would be in a better position to tell you how they interpret the language. I think the providing services to individuals with mental conditions in a home or community setting that are Medicaid reimbursed under our global commitment waiver seems fairly broad.
you think that covers?
I would,
The school part of the community, I guess, is what as a definition.
well, it's in a home or community setting. I mean, what we talked about in the Human Services Committee is sort of the other category is we call it sort of institutional, like residential institutional setting, like a nursing home, like a private non-medical institution, PNMI. And in part, those are the ones for which Medicaid rates are otherwise established by statute or rule. So that's how we were trying to make it clearer. So I don't read this as excluding schools, but I would need to defer to the agency to tell you how this fits. And I also don't know the extent to which some of those programs are under our Section 1115 Medicaid demonstration or through a separate federal program.
Alan?
You're talking about adults and mental illness. It said long-term service support for older adults and adults with physical disabilities.
That's an A.
Okay, so,
Yep. So it's this whole list.
yeah, okay, but the age,
So when we get down to B and C, there is nothing about age.
okay. So it's anyone.
Right. So
Okay, so I just was confused by, they mentioned adults, then they do away with.
right, because for an earlier iteration, A and B were specific to choices for care, which is older adults. And then they wanted to pull that reference to global commitment and put it at the beginning.
Woody, did I see your hand up?
You did, but I think I've listening to Ms. Carby and Senator
And nickel.
that my question has been answered. I was curious whether or not it was just for mental or developmental intellectual disabilities, but it
Nope.
covers
No.
other
Yep.
things
Yes.
as well.
In fact, I have been asked to take out the word physical before disabilities on line 17 on page 1, which I will do for when I was down the hall, which I will be doing for them for this afternoon, in addition to the updated effective date.
Anyone have any other, Brian?
It's just quick definitions. That there's a section that said extraordinary financial relief, and you said that that's an existing thing. Is there a place in state law that defines what extraordinary
It's in the nursing home rules.
in the rules? Okay, we don't need to get into more. I can look into it. I'm just curious what you were referencing. And then the second definition, and once again, it's not like we have to get deep into this, but is there anywhere in statute that defines home and community-based services? Because if so, I just want to read what that definition is at some point. Like, for example, is hospital considered facility? So it's not home and community-based, or is that community-based?
It's considered. I mean, it's my understanding that a hospital is a facility or institution,
So it's not community-based.
so it's not community-based.
Exactly. That's what I thought too. So I had that. So we'll look into this more later because it's not that important right this second. But when you mentioned that, when we were talking about extraordinary financial relief, I wondered where the definition was. And then just now when we were talking about what services are covered or not, then it made me wonder, is there a place in statute that defines it? That's all.
Not really. That was
Okay.
part of our struggle in
Yeah.
human services and trying to craft this definition.
Thank you.
Any other questions? Oh, yes, of course.
For the
Sorry.
record, Noel Langwell, Joint Fiscal, I just want to also highlight that this bill has like report backs and it's everything about creating a methodology It doesn't require actual rate increase. So I want to make sure that people were clear on that, because if it did, then it would be a fiscal note. Whereas it is right now, this is just the methodology and report back. So I just wanted to make sure people understood that.
No other questions? This, or do we just
Yes,
want me to convey to Human Services that
I think we should.
our
do-
questions have been asked?
I don't know if I'm comfortable enough to take a straw vote of any kind right now. It's
That's reasonable because we haven't really heard anything on it.
because it's a study, so there's no money involved at this point. Okay? So I don't know at this. And I guess some tough questions is this for any adult or Medicaid adult?
Adults, so this is only for services provided to people on Medicaid.
Yep. So there will be a cost when the study's over.
So it's not really a study so much as it is ongoing information. So then it will put the information in front of the legislature to decide whether to appropriate additional funding or not. I think part of what was discussed in the Human Services Committee is that annually you hear from a number of providers that the rates are not sufficient, and they want to know what would be sort of what would be a sufficient rate, and where does that gulf?
There's a lot of unknowns, It's full one way or the other.
I'm trying to understand.
I don't think we need to take a straw poll on this at
I'm
all.
trying to understand the difference between a straw poll and not a straw poll. Like, how does it impact anything?
It doesn't.
So then let's do what's simplest.
What's simplest is that
You go and
have
talk.
Human Services,
Yeah.
that we listen to it and we don't have any big glaring concerns.
There we go. Thank you.
I will do that. All right.